Start, please.
Good evening, everyone. Myself, Dr. Ramya, Clinical Head Fertility Specialist at Oasis Fertility Center, Guntur branch. I welcome you all for the Facebook live session. And today's topic for our discussion is PCOS, regarding PCOS and their various scenarios, how they are presenting, and what modes of treatment we are opting. So this is what we are going to discuss today. So in our previous session, I have already discussed regarding the PCO morphology and the causes, then its implications I have discussed in the earlier session. So, but a brief recap of the PCO regarding the PCOS. So, the causes of the PCOS may be polycystic ovarian syndrome. So, what is PCOS? Is the main thing is the polycystic ovarian syndrome. So, the causes regarding the PCOS may be a genetic cause, or else the hormonal changes, and the third one is our lifestyle implications. So, these three together are the causes for the generalized PCO, what we are seeing the polycystic ovarian syndrome in our many patients. Almost whoever are entering the clinic, if we sort out the percentage, most of them are likely into the category of the polycystic ovarian syndrome. So these are all in brief the causes of the PCOS. And the pathophysiology and what is causing this PCOS? The causes are the genetic cause and hormonal imbalance, but how it is causing the disease in us, or what are its implications, by what mechanism the imbalance is happening. So, in the polycystic ovarian syndrome, the main pathophysiology is lying behind the insulin resistance. The patients most likely they'll have the insulin resistance, and the other one is the imbalance of the sex hormones. Means there will be the androgen levels are more in these patients. So all this together is leading to the polycystic ovarian syndrome. So how it is manifesting? When a particular patient, to say they are PCOS, what are all the manifestations they have? First and foremost thing we see in them is the irregular periods. Second thing will be the in the scan finding, there are polycystic morphology will be there on the scan finding. So it is like a small cystic spaces seen in the ovary, multiple small cystic spaces seen in the ovary with immature oocytes. That is how the scan picture will be there in the polycystic ovarian syndrome. And third thing is the high androgen levels. Okay, hyperandrogenemia will be there in the polycystic ovarian syndrome. So the diagnostic criteria, in order to say they have the polycystic ovarian syndrome, is the hyperandrogenism and this irregular cycles or anovulatory cycles and polycystic ovarian morphology on the ultrasound. So this is in brief recap regarding the polycystic ovarian syndrome. So now coming to the various scenarios, how the PCOS patients present to us. So PCOS can affect in all the age groups from the adolescent to the menopausal age group. So in first and the foremost thing, adolescent age group, a girl, she is around 18 years and unmarried, coming with the complaints of the irregular cycle since menarche, and there is history of excess weight gain for her and unwanted excess hair growth seen on the upper lip, chin. Then her BMI is around 30 kg meter square. So BMI is nothing but, so average BMI వచ్చేసి మనకి 24 ఉండాలి. So if it is above 24, it comes under the obese category. Or so when the BMI is regarding the based on their weight and the height. So whenever the BMI is more than 25, they come under the category of this excess weight. So in this case scenario, if you see the patient, she is 18 years and presenting us with the irregular cycles, excess weight gain, and unwanted hair growth, more likely towards the polycystic ovarian syndrome. So, in this patient, what are all the treatment options? So, her parents are worried mostly about her irregular cycles and the unwanted excess hair growth. So, first, how we are going to evaluate this patient? Regarding this patient, her basic hormone evaluation will be done. Once her thyroid levels or prolactin levels seems to be normal, then in the whenever her in ultrasound, she has the features of the polycystic ovarian syndrome. So in this case, we need to rule out only the other hormone profile abnormalities once when all that abnormalities were ruled out, and when she is diagnosed to have a polycystic just because of this irregular cycles or due to the polycystic ovarian syndrome, then um, try to what is the management in this case, what can be done is, first thing we need to advise to reduce the weight and her lifestyle modifications. So regarding that, the advice is to be given. Little of this, almost 5 kg of her weight reduction will make her cycles regular. So I have seen a case of this same patient when we have advised her and she has followed her diet correctly and has done exercise, and when she lost her weight, her BMI has come to almost to 26 kg per meter square. She had regular cycles, but once after again in a short duration, once whenever again she started gaining weight, she had the irregular cycles only without medications. Once even with the weight reduction, she had the regular cycles, means ovulatory cycle she had. And so in such sort of patients or in these patients, usually we try to correct regarding the weight gain and the exercise and diet lifestyle modification. And second thing will be, in case if the irregular cycles, we can give the occipital treatment in order to regularize, but it is not advisable regularly, only at a short duration. But important thing is only the diet and exercise, but we can give medications for the insulin resistance to control, so that will be more helpful. And also antioxidants also can be given in such patients, which will be helpful. So this is what can be done in this age group. And regarding the excess hair growth, the hair, we can at least with the proper management, uh, we can prevent that excess growth, not the one which is already there, but once the treatment is given for such patients, we can control even the excess hair growth. So coming to the next case scenario. So this is a couple aged 24 years. Wife is around 24 and the husband is 25 years, and they are married for 1 year. This patient has irregular cycles. So her cycle length is around 35 to 45 days, and her BMI is 30 kg per meter square. This is also more than the normal, and her basic hormone profile seems to be normal. So regarding hormone profile, in the sense, all the thyroid hormone profiles or the prolactin levels, FSH, but LH is slightly raised in this patient. So regarding other evaluations is normal, but slightly higher LH level is seen. Rest of the profile seems to be normal, and her husband semen analysis seems to be, the count seems to be normosospermia. So it is normal count in this couple. So here the patient is married only for 1 year, and haven't undergone any treatment. So irregular cycles here seems to be, these are the anovulatory cycles. So in such a couple, what are the treatment options? So what we usually advise in such a patients with a marital life of only 1 year with anovulatory cycles, we can try some ovulogens, ovulation induction agents, and to increase the follicle growth or the egg growth. The medications can be given and can be monitored on the scan, and once in the scan, if we find the follicle is growing in a correct manner, we can um, even trigger that patient for the release of the egg. Okay, and once she is ovulated, we can help them even for the natural time intercourse. We can tell them during the period of that ovulatory cycle. So, sorry, during the time of ovulation. That ovulation can be determined even in the scan. Once if we see the follicle is ruptured in the scan, that determines the ovulation. So, during the time of the ovulation, if there seems to be if they'll have a timed intercourse, they'll have more chances of the successful for success towards the pregnancy. So, so with a shorter duration of the marital life and with only regular cycles of 35 to 45 days with the normal hormone profile, with the husband semen parameters normal, they can go for the simple ovulation induction cycles with the timed intercourse. That will help for the pregnancy. In case of the delayed cycles, then the further management can be done in them. But initially, they can follow the simple ovulation induction agents, and they can try for the pregnancy at least for 6 months. They can see once if the follicles are responsive and they are developing, they can try it out for 6 months. In case if the follicles are not responsive, then the other modes of treatment should be given to such patients. So, and this is regarding this case, and our second case is the, so in this patient, the wife is around 28 years and the husband is around 32 years. They are married since 2 years, 6 months. In this patient, she is having irregular cycles of duration 60 to 90 days. Her BMI is also more, it is around 32 kg per meter square. Uh, and they haven't undergone any treatment so far. Medical management regarding the infertility, they haven't undergone any treatment so far. So initially, they have done a HSG. So HSG seems to be normal. Her tubes, bilateral fallopian tubes, seems to be patent. And initial other investigation is the husband side semen analysis showing mild oligoacinospermia, and husband is having the erectile dysfunction. So in this couple, both the factors they have, means even the male factor and the female factor. So female factor is here, she is having PCOS or anovulatory cycles with high BMI, and husband male factor is the erectile dysfunction along with the oligoestino. Oligoestino in the sense sperm count is very low in such a couple. So in these patients, what are the treatment options? So here both the male and the female factors are there, but one good thing here is her both the tubes are patterned. So here they can opt for the IUI. These couples can go for the intrauterine insemination. So here what is suggestible most likely here, once with the ovulation induction. So for the growth or the development of the egg or the follicle, we give medications and we monitor in the scan Once the follicle is growing to a proper size of 18 to 20, we try to trigger the follicle for the ovulation. Once the follicle is ovulated, they can, the same day they should be subjected to the IUI. So here in the IUI, the timing of the IUI is also important, because the once the oocyte, or the once it is ovulated, the oocyte can be only for 24 hours. So within this 24 hours, we need to do the IUI, or the intrauterine insemination, which will be helpful in the successful pregnancy. So in this scenario, in this case scenario, IUI will be a better option for these patients. Without any other comorbidities, IUI can be done in this case scenario. So our third case scenario is here the couple aged 31 and 34 years with the primary infertility. They are married for 5 years duration, and here also the wife is having irregular cycles, and she has only withdrawal bleeding, means only with the medication she is getting her cycles. Otherwise, she doesn't have any periods, regular menses or the periods. Only with the medication, with the progesterone medication, she is able to get the withdrawal bleeding. Here the BMI is more. Here the BMI is more. It is around 38 kg per meter square, and previous treatment she has undertaken. She had taken multiple cycles of ovulation induction with the timed intercourse, and she even had 3 IUI cycles which were failed. But her, even her husband, the semen analysis is showing oligoacidosis, means here the semen count and motility is also low in this case scenario. So, in such a case, what are the treatment options in this case scenario? So, already they have been above 30 years. First thing regarding the age, and the marital life is also more of 5 years, and anovulatory cycles with the huge BMI of 38 kg meter square, and tried multiple cycles of naturally they have tried multiple cycles, and IUI cycles they have tried for 3 cycles. Since all these cycles they didn't have any result, in such a couple, in such a case scenario, uh, first we need to evaluate whether any other hormonal problem is there. Once after the basic initial evaluation, and after confirming no other comorbidities along with the PCO, we need to advise weight reduction in such a patient with the proper dietary advice, first thing. And these patients are likely, means for them, the likely choice will be the IVF or the ICSI, because almost they have tried n number of cycles. So in such a couple, the option again it will be going for the IVF or the ICSI will be the better option in this couple, and a test tube baby option is right choice. But the thing is, once if we come to know almost irregular cycles, 6 cycles we can check it out, and after 6 cycles also, if there is no result, then you can opt for the IVF. But many of the patients, what they have done, what they are doing is, uh, after having undergone n number of multiple cycles, only they are opting for the IVF. So, which is causing a little delay in the treatment, and a little backdrop is also happening in such couple. So, if already marital life of 5 years, and you can see up to till 3 years also, later you need to opt a better option for the success of your pregnancy. So my sincere advice is not to delay much time after. If you're married, you can wait up to 1 year, 2 years. Okay, after 2 years, you need to take a heavy decision faster. So our fourth case scenario is here the couple is around 28 and 34 years. They are married for 6 years. Uh, Even here, she has irregular cycles, which were around 45 to 60 days, and she is having severe dysmenorrhea during cycles. Her AMH level is around 5.2. Her TSH prolactin level seems to be normal, and her BMI is 30 kg per meter square. She has underwent 2 cycles of IUI, which were failed in the past, and she has underwent lap endometriotic cystectomy. Okay, so this patient has got, along with the PCO, she is also having endometriosis. So endometriosis as such is one of the cause for the decreased oocyte quality and decreased implantation rate. Here, the patient has got both the problems together. One is a PCO and the other one is the endometrioma. So, the endometrioma itself determines it is almost a grade 3, and the patient underwent endometriotic cystectomy in 2020. But again, she has the recurrence of that cyst bilaterally, but her reserve is good. Her AMH seems to be 5.2. So here in such patients also, even if the cyst is of a smaller size, say if it is less than 4 centimeters, they can directly go for the IVF for the ICSI cycle treatment without prior going for a surgery. If a cyst is a bigger cyst, or which is causing hindrance to retrieve the other follicles. In such cases, only the endometriotic cystectomy is advised. Otherwise, directly they can go for the IVF treatment. And once after the IVF treatment, after the oocyte retrieval, we can have this down regulation for the endometriotic cyst and then go for the frozen embryo transfer, which gives the better success rate rather than delaying with the lap surgical procedures. So, so in this case, the same thing. The patient has both the polycystic, she is having anovulatory cycles along with the endometriosis. Husband semen analysis seems to be so here male factor is normal, but the female factor is the cause for the infertility in this patient. So here the proper plan will be the IVF, which will be helpful in such a couple. So we have a patient with the we have a success history of this patient. This same patient has undergone the cystectomy, and then she has a recurrent cyst. Again, she has gone for the IVF cycle. She had got 6 embryos, and out of that, she has a one blastocyst transfer, and she conceived in the first cycle. She has a and even she delivered at around 36 weeks, female baby, which is healthy. So even better not to delay much. If we delay much, the reserve ovarian reserve may be far. It may become even less. That is why better to take treatment immediately, even in such patients. If you go for a recurrent lap cystectomy, the reserve will be lesser. Ovarian reserve. Here the AMH is good, 5.2, and the reserve is better, so that this cycle has, I mean, this patient has a better successful embryo and successful pregnancy. So our next case scenario, here the couple is above 30 years. She is 32 years and the husband is around 37 years, with the infertility, primary infertility, and they are married for 4 years. They have irregular cycles. Cycles are around 60 to 90 days, 2 months or 3 months. She is having her cycles. Her BMI is 20 kg per meter square. So this is the case scenario. What I want to tell is here, she is a lean PCO. So usually all the PCO patients tend to be obese, but even they are lean PCO. So this patient comes under the category of the lean PCO, and she already has underwent lap ovarian drilling. Until laparoscopy, she underwent a surgery for the for the PCOS. They have done the lap ovarian drilling. So here, what I want to tell here is the lap ovarian drilling can be done, but it should be with the low voltage current for the less time. So 40 watts current for 4 seconds it should be done, and only 4 puncture sites. If it is more than 4 punctures and more than 40 watts current or more time, if we are delivering that, if we are doing the lap ovarian drilling, we are going to decrease the reserve in such patients. So for the later half, they will have the difficulty in conceiving. So we should be we should try to limit the puncture sites to only 4 puncture sites and 40 watts current. So that will be helpful. Otherwise, better the lab ovarian drilling should be only as the last option, not as a first option. First, we need to try all these measures what I have already said. Like they can try with the medication. One is the lifestyle modification, diet, exercise, and for medication for reducing the insulin resistance, antioxidants, and oral ovulations or the ovulatory induction agents, and with the addition of the gonadotropins. All these should be tried, and then the patient should be subjected for the lap ovarian drilling. The lap ovarian drilling should not be the first mode of the treatment. It should be the last option for the treatment. And in this patient, that is the thing, we should not damage more of the ovarian reserve. That is why it should be the last option. And here, the male factor is also there. The husband's semen analysis showing oligoacinospermia. So here the count and the motility seems to be low. So in such a couple, again, we can go for the IVF cycle, because already they have been trying multiple cycles. But in this patient, what has happened is, earlier she has underwent the lap ovarian drilling. So the drilling was done with a multiple punctures. All her reserve being lost so much, she was into a poor reserve, and that is how she has got only a less number of oocytes. That is how we want to tell this lab ovarian drilling should be as a last option, because in few patients it is creating so much of damage in the ovary. So even in this patient, the option will be the IVF ICSI for this patient. So this is the last case scenario. In this patient, this couple is 31 and 36 years couple. They are married for around 5 years, and the wife is having regular periods, and she has only withdrawal bleeding. That means only with the medication she is having that bleed. Her BMI is around 28 kg per meter square. She also underwent multiple cycles of ovulation induction with the timed intercourse, but still there is no response. And also, she had with the IVF cycle underwent IVF cycle. Still, there is no response in that patient. Her husband's semen analysis is showing normozoospermia. Here, here in this scenario, what is the problem here is the patient has got a FSH receptor problem. So how much ever medication we are giving, because of the receptor, the follicle is not responding. So very few cases we have like this in the PCO patient, that is a receptor problem, or that enzyme which is acting on the receptor as problem. So in such patients, because of this some genetic mutations, they have this problem. In such patients, the treatment option will be the in vitro maturation. So in vitro maturation, what we does is we need not give the gonadotropins. So the follicles are retrieved as such from the ovary, and that immature follicles will be matured in the lab under proper lab conditions. And once the follicles are mature, on those follicles ICSI will be done, and later on the same as is done in the IVF. So only differentiation thing is immature follicles are taken out and they are grown till maturation in the lab. Once the follicle is mature, then they will be undergone for the ICSI. So that can also be done in such a patients. These are all the very rare case scenarios. And one more thing, what I have missed is a few complications in the PCO patients. Whenever they undergo for the IVF, we should be very careful regarding the hyperstimulation. So every we need to monitor for the hyper whenever they have undergone for the IVF, they are more prone for the hyperstimulation, ovarian hyperstimulation syndrome. So they should be monitored and treated properly. Once uh, under proper monitoring and treatment, it doesn't cause much problem. But if we miss the diagnosis of hyperstimulation, it may land up in the critical problem to the patient. Even it may even land up in an emergency uh, problem in such patients. So these are all the case scenarios what I want to discuss. So thank you so much. So these are all regarding different PCO patients with the various with the various scenarios, how they present to us and how we view the treatment. So thank you so much. If you have any questions, you can put up in the chat box. Okay. Our first question is, are there any new treatments for the PCOS? Yeah. PCOS patients, whenever we are planning a protocol for in the IVF session, we try to follow this antagonist protocol and the agonist trigger. That will be helpful for preventing the ovarian hyperstimulation syndrome. And the newer modality is the in vitro maturation. So without giving for what to say, 10 to 12 days of these injections, only 3 days of these injections can be given, and the immature follicles can be retrieved, and those immature follicles are matured in the lab by culturing. So that is in vitro maturation. That is one other newer treatment for the PCOS patients. What is the first line of treatment for the PCO patients? So usually first line of treatment in the PCO patients, if you see the marital life is shorter, just with a simple ovulation or the ovulations or the ovulation induction agents, means in order to improve the follicle growth, the medications will be given. That will be the first line of treatment. Even with the ovulations, if they are not working, or once the follicle is not responding, then they need to be subjected to other modes of treatment. How can I naturally regulate my period with PCOS? Um, See, in this, what can be done here is you need to do proper exercise at least daily for half an hour to 45 minutes, and diet should be um, diet control should be there with a proper protein diet with decreased carbs and the fat and routine exercise. These can be helpful. Does PCOS mean poor egg quality? Even in the PCO patients, the egg quality is poor because they have got hyperandrogens. Androgen levels are more in their blood. So usually we can expect the poor quality eggs in the PCO patients. Is IVF successful with the PCOS? Yes, surely yes. Here in the PCO, whenever in the IVF scenario, once rather than other infertility problems, PCO patients will have the best success rate when compared to other fertility problems, infertility problems. So I guess we are done. Thank you so much. We'll meet in another session. Thank you.